Welcome, everyone. Welcome, everyone. Let's wait for the others to join, okay? Good evening, Caleb. How are you? Let's wait for the others to join, okay? Let's wait for everyone to join. Right. Right. Right, let's wait for the others to join. We give ourselves 2 minutes to start. Okay. Let me know if you can hear my voice. Let's wait for the others to join. Okay, thank you, Sarah. How was your weekend? Right, so the 2 minutes is up. So let me share the screen so that we can start as soon as possible. Okay, I'm not going to spend much time. Okay, can you see my screen now? Okay, so a lot has changed with Nclex nowadays, and you and I are witnesses to that. People who have written and come back testified that the questions have changed, the scenarios have changed, and everything too has changed. Okay, right. So if the system is changing, then we too must change. Then we have to change the way we learn, the way we view things, or the way we focus on how things are moving. Okay, so it is even easier. The good thing is that it's even easier. It can make someone prepare for NCLEX within a short time and practice NCLEX. If only you are smart. Yeah. So I want to take it one by one with you guys. Okay. I want us to go purely by the curriculum. Okay. The new 2026 curriculum, the areas with which NCLEX exams are being set. So the other time, those of you who joined this platform for a long time, the other time we did management of nursing care. Okay, it is one area that NCLEX looks at, management of nursing care. Okay, NCLEX also looks at safety and infection prevention. They look at pharmacology, psychology, okay, so many aspects. And one another area that they set questions from is physiological adaptation and critical thinking. Physiological adaptation and critical thinking. Okay. So I want us to start today. If you are able to finish today, good news. Okay. If you are not able to finish, tomorrow is there. We will continue. Okay. But I'll try my best to explain the concept like I always do. Once you get a foundation, applying it to the questions and applying it to clinical scenarios will be so easy for you. Okay. Right. So uh okay. Yeah. So let's continue. Let me know if you can see the screen well. and let me know if everything is okay. So, physiological adaptation. Okay. My name is Paul Bright. I'm your registered nurse. Okay. So, NCLEX tells you or will shape the way you focus. Okay. The way you think, the way you prioritize, you act and evaluate. The same thing. That's the basic concept of physiological adaptation. A patient has come to your care, okay, has come to your bay, has come to your hospital. They will surely come with their problems, their concerns. Okay. So you listen to it, you collect your data, you think about it, you recognize their issues, you recognize their cues, okay, out of the data you've collected. Yeah. Then you prioritize it. You prioritize hypothesis. That is what we say. You prioritize, you act on it. Okay. Then you evaluate whether the action, the what you did for the patient, did it work or it didn't. If it didn't, then you reassess again. It is something we have been doing as nurses since day one. Okay. Yeah, in nursing school. So every nurse you need to what? Reassess or reevaluate. Okay. So what is physiological adaptation? According to NCSBN, okay, according to SB, they are the ones who set the NCLEX. They have been it is a body that sets the NCLEX the whole world. Okay, according to them, they are saying physiological adaptation is the nurse's ability to recognize how a disease or injury changes the normal body function and then determine how to assess, prioritize, intervene, and evaluate patients' response. Okay, so the long and short of it is that the board is telling us that they are not looking at what is heart failure, those simple things, the way we write exams back home and those types. Okay, so that is not their focus. Okay, like we go to school the whole semester and we ask you what is hypertension, what is asthma, what is this? No, somebody can stay in the house and learn. Okay, chew that definition and come and write it down, and you call the person successful, give the person license. Okay, but when you go to the hospital, the patient who is coming to the hospital will not come and ask you what is heart failure. No, they are bringing a heart failure scenario that you must what attend to them and save their lives. Yes, you know the definition of heart failure, but when we give you a clinical scenario of heart failure, you don't know what to do. That is all about physiological adaptation. So it is more likely to ask a client with heart failure suddenly develops which findings, rather findings that requires immediate nursing intervention. Yes, so this is another aspect of it. Okay, so what they are trying to say is that you should understand the etiology, okay, the cause, the root cause, okay, after knowing so heart failure, what are some of the causes? Okay, you know what is the pathophysiology of the causes that you identified. Let's say, for example, if one of the causes is heart failure, is one of the causes of heart failure is hyperlipidemia. Okay, how can you link? How can you explain for hyperlipidemia, for high limit or higher levels of lipids? Okay, to you link it to heart failure, there should be that connection. Okay, after that you look at the clinical manifestation, the diagnosis, then you prioritize your care. Okay, you prioritize the care, or you prioritize the data you've collected, the interventions. Okay, then expected outcome and complications. Yeah, so let's go down. Whilst we move ahead, you understand the concept well. Okay, so what is the framework For every nurse or for every health worker in this world, if you want to understand physiological adaptation framework, you need to ask yourself these 8 questions. You can write it down. Okay. Ask yourself these 8 questions. Okay. Number one, what caused it? Okay. Example, someone has come with heart failure. What caused the heart failure? Ask yourself. We went to church, someone has collapsed. The first question you should ask yourself is what caused the fainting or the syncope? Okay. What caused your child to vomit? That is the first thing. If you don't ask this question, you have not started the journey of what? Physiological adaptation. Good. Now, the second question you should ask yourself, according to them, is that what is happening inside the body? What is happening inside the body? Okay, that is where your pathophysiology comes in. That is so you have known the cause. Okay, a baby is vomiting. Yes, we know that this is what a bacterial infection. That is the cause. Okay, how can we link that bacterial infection to the vomiting that is happening now? That is what we call the pathophysiology. Okay. Now we look at the next question. What will I see? So now you know the cause, you know the physiology or the pathophysiology. So what are the signs and symptoms you are looking at? What will I see with this patient? Okay. So you see the temperature spiking. Example, you see they are weak. Okay. Yes, you see some of them having seizures and all these other signs and symptoms. So you list all these signs and symptoms down, and clinically to what is the patient presenting? The skin is cold, the mucous membranes are dry, they are having projectile vomiting. So all these ones you listed down. Yes, now you know. You know what the books are saying. Let's move on. What will the laboratory, the next question, what will the laboratory or diagnosis test show? This will help you with your diagnosing of the vomiting. The example, the scenario I'm giving, it will help you. Okay. Now, you remember you listed the signs and symptoms, and now you know what the diagnosis. Okay. You know the diagnosis. Now, the question is that all the signs and symptoms and all the laboratory tests you have done, the results you have gotten, and the signs and symptoms, the answers you have gotten, which one of these will kill the patient first? Okay, which one of these will kill the patient first? That is where your priority comes in. So you see how the things are changing. First, they used to end here. Before Nclex, they used to end at the diagnosis. Okay, you define, you do everything. But now they've added the new concept, which I'm explaining to you now. Then if you go by this way, you are able to deal with any human being that comes to your care. Okay, so somebody has come to you with headache, fever, diarrhea, okay, vomiting, all these for all signs and symptoms. You did your laboratory investigations. Potassium is high or potassium is low. Okay, WBC is high. So you ask yourself, the headache, fever, the potassium spiking, which of these signs and symptoms and which of these laboratory results will kill the patient first? This is where the story starts from. So you prioritize, you know that, okay, potassium, if you don't do something about the potassium, it will kill the patient first. It will cause a weakness. So let me go there and what? Deal with what? The potassium. So now you know the answer. Okay, what should the nurse do? Is the nurse supposed to prescribe potassium? No. So over here, we talk about what? Intervention. Intervention is two types. One, they can bring a question like, what should the nurse anticipate? Okay, when it is not within the scope of the nurse. So everybody knows that the nurse cannot go to pharmacy and pick potassium and come and give to the patient. Definitely, the nurse will do what? Will ask the doctor to prescribe potassium. So whenever they are going to, when they take a scenario like this and they want to ask you, they have two ways to go. The intervention, is it within the scope of the nurse, or is it outside the scope of the nurse? Okay, if it is within the scope of the nurse, then what they will ask you, what would the nurse do? What intervention would the nurse do? If it is outside, they will ask you, what does the nurse anticipate to be done? That's it. Okay, so while the intervention has been completed, the next question and the last question we should ask ourselves is what? What complication am I watching for? Yes, you have given your potassium. That medication you gave, it has a side effect. When the medication enters into the bloodstream or the serum of the patient, will the bloodstream accept it that there will not be any trouble? So, what are the complications, likely complications I'm waiting for? Okay, so this is a disease analysis method. If you get these areas, you are done. You are done. Okay, right. So, the physiological adaptation topics we are going to look at, that they brought it out. So the 2026 NCSBN review test plan, okay, they have focused, they have their master courses, and I have all of them. You should count yourself blessed to be part of these lectures. Okay, yes. So it includes management of clients with impaired ventilation. Okay, we will look at the system by system. Okay, then the fluid and electrolyte, altered hemodynamics and tissue perfusion, dialysis ventilators, emergency care, post-operative care, drainage systems, invasive procedures, and recognition intervention for complications. Okay, I've already told you that the NCLEX you are going to write, they are going to give you 9 different areas, whether you like it or not, unless you don't register for NCLEX. 9 different areas. We have already done the management of nursing care. You remember every Wednesday, I take you through the 9 areas. We do questions on that. Okay. So every Wednesday, tomorrow, we are going to do questions on the 9 areas. Then you score yourself. And all the 9 areas, you should get above average before you pass for NCLEX. So one of the areas is what? Physiological adaptation. And they are saying, per their 2026 review, all the questions that will come under physiological adaptations, here are they. So if you are learning now, you know where to direct your learning to. Management of clients within impaired ventilation, all this, I'll give you the slide, you get it. Okay. I just want to explain to you, and so that you get the basis and life will be simple for you. So they are master topics. That is what I'm going to show you now. They've done a system by system. They are saying that until somebody comes to the exam room, that the person is ready for NCLEX, they should know all these topics and know how to manage them based on these questions. Okay, because they are going to ask questions from all these areas, of all these questions. So any question you get under physiological adaptation is going to come from all these areas. They will ask you, what does the nurse anticipate? What is the nurse's action? What are some of the likely causes? They will do the bow tie. Okay, they can frame it in so many ways. Okay, yes. So let's look at the master topics. So with the cardiovascular system, you and I, as you are listening to me now, they are saying, don't enter the room if you don't know this, how to manage these conditions. Because if you get questions there, it can torment your life. So 1, myocardial infarction, heart failure, cardiogenic shock, okay, hypovolemic shock, septic shock, anaphylactic shock, dysarrhythmias, cardiac tamponade, pulmonary embolism, aortic dissection, and hypertensive crisis. These conditions, when you come to the United States, it is something that keeps coming. It rotates, especially those who work at the emergency unit. It will be on your fingertips. Even the healthcare assistant who is working in the ER or the ward knows what to do when a patient with MI comes to the hospital. Okay. So example, if you take myocardial infarction, if you want to manage myocardial infarction under physiological adaptation, this is what you should do. Okay. The patient has come with what? My MI. You don't have any diagnosis. The patient is definitely coming with chest pain radiating to the shoulders or the neck. Okay. They are having shortness of breath. They have taken their medications, okay, the glycerins and the nitrogens, the 3 times or the 2 times. The pain is not going. Okay. Yes. So these are the complaints they will bring to you. Or maybe ambulance has called. We are bringing a case of what? Suspected MI to you. So the next, you should ask yourself, what caused the patient to get MI? If it is true that the patient has MI, what caused it? So you should know the causes. Okay. Now you should know what is now the question. Next question is, what is happening inside the body? According to the books, everybody knows that MI is caused by what? A plague, okay, or whatever, a thrombus, whatever that has blocked what? Any of these coronary arteries. That is what the books are saying. Secondly, what is going on inside the body? It can be something else outside what the books are saying. Okay, so you gather all these information quick. You are thinking within 3 minutes, 2 minutes, you know all this. Then now the patient has come to you. You ask yourself, what will I see? What are the signs and symptoms I'm seeing? When the ambulance called you, what are they saying? Okay, what are the signs and symptoms they are saying? So when you want to link this one to S bar, S bar will say that what is the situation? The S, what is the situation of the patient currently? So the S, okay. Now you know you are a nurse. You are treating myocardial infarction. Okay, what laboratory investigations are you going to do? And what diagnostic test? Your EKG. You take your blood samples for the SSTs or the chemistries. Okay, you know your troponin, your BMPs, and all those stuff. The results will come. So when the results come, coupled with the signs and symptoms, you know your diagnosis. Now the results have come. Troponin is shooting up. Okay, potassium is somewhere. Myoglobin, all these ones, BMPs, they are all over the moon. Okay, we are treating MI. Now you ask yourself that what can kill the patient first? Everybody knows that troponin is very dangerous when it starts shooting up in MI. Okay, it means that the heart muscles are dying. And that enzyme inside the heart muscles, the cardiac muscles, they are being squeezed out into the blood. That is why the troponin is shooting up. What can I do to save the dying muscle? Okay, so you focus on the troponin. The troponin is shooting up. You did vital signs. You saw that you had the result that temperature is 40 degrees. So the troponin and high temperature, which one can kill the patient first? That is where your prioritization comes. So NCSBN will ask the question that which of these will the nurse prioritize first, or which of these things will the nurse attempt first? Priority questions, physiological adaptations. Okay. Now, what intervention should the nurse do? You have picked your troponin. If troponin is shooting up, okay, what are we going to do? We should prepare patient for cath lab. We should activate the cath lab. We should inform the cath lab. We should get the cardiologist. Okay. So what is the nurse also doing in his scope and outside her scope? So the intervention is always two branches. Is it within my power or outside my power? If it is outside, you anticipate. The question will ask for anticipation. If it is within, they will ask what will the nurse do? Simple. Let's continue. How do I know the interventions have worked? Okay. Yes, we took patients to cath lab. We have taken the clot or whatever was blocking the coronary artery out. Okay. We have done all the cardiac catheterizations and everything. Patient is back to the ward. How will I know that the intervention we did has worked? Okay, let's go and take troponin again. Sometimes nobody does that. But for curiosity, let's go and take troponin again. You go, troponin has come back to normal. Simple. So it has worked. Okay. So what complications after the cardiac catheterization am I expecting? Okay. There can be bleeding again. There can be arrhythmias. Okay. So you sit down and be waiting for those things. Then you prepare for that. Yes. So this is what they are saying. So please, cardiovascular system, this is what the conditions we are looking at. Okay. With the respiratory system, don't come to the exam room if you don't know how to manage asthma under these topics. If you don't know how to manage COPD, which you and I will know, okay, pneumonia, pneumothorax, hemothorax, pulmonary embolism, acute respiratory distress syndrome, ARDS, respiratory failure, acute airway obstruction, mechanical ventilation. Okay, so when a patient is coming, at what point are we putting the patient on a machine, a ventilator, from the machine to breathe for the patient and breathe in oxygen and take out carbon dioxide? So you should know all these ones. Okay, let's go to the neurological emergency, stroke. You should know ICP, increase intracranial pressure. You should know what is causing this patient to have increased intracranial pressure. Is it blood? Is it tissue? Is it a tumor? Or what? Is it CSF? Okay. Seizures or status epilepticus, traumatic brain injury, spinal cord injury, meningitis, and brain herniation. Now they move toward endocrine. So you see, before Nclex, you start with what system by system, then you chew it, baba. Yes, system by system, you learn. Now they are saying that okay, put away the system by system. Let's go with these master topics. Come, physiological adaptation, clinical scenarios. Come and answer question. So before they will ask you, what is brain herniation? Then somebody will write. They will get 100 over 100. Now they will bring you signs and symptoms of brain herniation. So you should ask yourself, what is causing this patient to have what? Brain herniation. What is happening inside? Endocrine system or endocrine emergencies, they are saying you should know your DKAs, your HHS, okay, the other brother of DKA, where insulin is not a problem. Hypoglycemia, you should know how to manage it under those questions. Okay. Thyroid storm, mixed edema, Addisonian crisis, SIADH, and diabetes insipidus. Okay. When you go to the renal emergencies, we are looking at acute kidney injury, chronic kidney injury, hyperkalemia, fluid overload, uremia, hemodialysis complications, and peritoneal dialysis complications. Yes. Okay. Yes. Somebody is receiving dialysis. All of a sudden started complaining of severe shoulder, severe arm pain. Okay. Yes. A complication has occurred. Something must be done. It is going to be done in this format. Physiological adaptation. Okay, yes. Now the GI, gastrointestinal and the hepatic. So we are looking at GI bleeding, bowel obstructions, perforations, pancreatitis, appendicitis, cirrhosis, hepatic encephalopathies, esophageal varices. Okay. The next under trauma and burns. So if you know your burns management, they will bring you clinical scenarios which you should be able to do. Crash injuries, compartment syndrome, spinal injuries, fractures, and head trauma. Then post-operative complication, those who will be working in the message, those who will be working in orthopedics, okay, those who will be working in PACU, post-operative, you are going to need a lot. Okay, they will not take a patient to theater and bring the patient to the ER. They is going to the ward, ICU, PCU, step down unit, okay, telemetry unit. So you should be ready to answer questions on hemorrhage. You should be ready to answer questions on atelectasis. Somebody has gone to theater and come back. Now the lungs have collapsed. What are we doing? Okay. Pneumonia. Somebody has come back with deep vein thrombosis. We had a surgery over 12 hours, 13 hours. Okay. Somebody has come back from theater with pulmonary embolism, wound dehiscence and eviscerations. Okay. Infections and urinary retentions. Yes. Somebody has come back from theater with paralytic ileus. This patient wants to eat. What are you supposed to do? Okay. Now they also added what? Fluid and electrolyte and acid base. So your sodium abnormalities, you should know how to manage hypernatremia and hypo, potassium hyperkalemia and hypo, calcium hypercalcemia and hypo, magnesium abnormalities, metabolic acidosis, metabolic alkalosis, respiratory acidosis and alkalosis. You should know how to. So these are the master topics that they are saying. If you don't know anything in this world, we have so many other conditions that if you want to list, we are going to list all of them. But they are saying these are the ones that comes often to the hospital. When we go to the community, the clinics, these are the conditions that comes mostly. So the nurse must know all these ones. If I were you, I'll focus on this. Master it. Okay. Yes. So now the priority system. The NCLEX, they are proposing the NCLEX priority system. When a patient has multiple problems, yes, a patient will surely come with multiple problems. How are you going to go? Okay. Aside, you and I, we developed our strategy, the AMASA, okay, that we used. So they are also doing what? The ABCD, which is part of the AMASA. So if you learn the AMASA, this one will be so simple for you. Okay. A patient has come with multiple problems, and they will ask you, what is the priority? What is this? Which of the patients will you see first? Yes. So one patient has different problems. How are you going to go? They are saying group the problems into A, B, C, D, E. Okay. Which of the problems fall under airway? Which of the problems fall under what? Breathing. Which of the problems fall under circulation? Which of the problems fall under D, disability, neurological? But over here, you don't have time. Remember, last week we did it because you are saving life. So, which two areas did we look at with neurological status assessment? Yes, send me your answers in the chat box. Let me know if you follow whatever we learn. Neurological status assessment, under emergency situation, which there are two. Which formulas are you going to use? Yes, send me your answers. Yes. You want to assess someone's neurological status. How are you going to do it? Under emergency. Yes, send me your answers. Let me know. Hey, I'm waiting for your answers. Oh. Yes. You went to sleep with your brother or your sister. We woke up in the morning. Your brother is severely confused, having seizures and all those stuffs. How are you going to manage it? And the neurological status. Yes, GCS is number one. Yes, level of consciousness also falls under neurological. Yes, so if level of consciousness reduces, it is neuro. You surely do a neurological assessment. By neurological assessment, we have GCS, that is number one, and the other one is what? Under emergency. Yes. Yes. Because the ER nurse, the emergency nurse who is in the unit and doing neurological status will do a neurological status different from the ICU nurse or the med-surg nurse. Because the ER nurse is managing what? Acute care. Hot, hot. So you don't have time to do an in-depth what neurological status. Yes, the AFPU, good. You are very good. Yes. So the AFPU, you do the AFPU quick. Okay. Yeah. So then the exposure. So if it is trauma exposure, if it is any other condition, exposure head to toe. Okay. So that's the E, number E, exposure. Eh? So they are saying that a clinical example, somebody brought the child, asthmatic baby, to the hospital. Okay. This child is having severe shortness of breath, cannot talk. And he's also having what? Silent chest. You did a stethoscope, silent chest. Okay. So they are saying this one person has all these multiple problems. If you want to treat and you want to go by that, start with the airway. Simple. Okay, start with the airway. Don't jump to D. You realize, I remember those days when a patient get accident and we bring the patient to the hospital, then we will cut all the clothes and be doing tepper sponging, cleaning their face. You are doing exposure. Meanwhile, the airway is there to secure. The breathing is there to check their saturations and everything. Okay, and the respiration rate, the oxygens, the circulation is there. You set up your IV line, IV fluid going, it's within your scope. Your blood pressure, vital signs, neurological, your GCS is there. Okay, yes. Don't jump to this. A baby has been brought to the OPD, convulsing. Okay, convulsing with stridor. Okay, convulsion with stridor. The stridor alone makes it airway problem. So you prioritize the stridor over the convulsion. That's it. Okay, yes. So let's look at some of the clinical scenarios. This is the basics. So let's look at some of the clinical scenarios. Scenario one is shock. Let's treat shock. Okay, everybody knows shock as a state of inadequate tissue perfusion, resulting in what? Insufficient oxygen delivery to cells. Okay, so this is the pathophysiology. You know the definition, a little patho. So it is either the circulating volume reduces, or the cardiac is not pumping well, or there is an abnormal heart vagal or vascular tone or nerve abnormality. The nerve is not performing well. Okay, so what that happens, The tissues that are supposed to receive the blood is they are not getting them. So tissue perfusion goes low. Oxygen travels with blood. So if blood is not getting to destination, definitely oxygen will drop. The cells always compensate. So if you are not getting blood, we are not getting oxygen, then let us try and help ourselves. Okay. They will use the carbon dioxide inside the cell that is supposed to come out so that we breathe out. They will use it to reproduce what? Energy again, ATP. We call it anaerobic metabolism. Okay. But whilst they are using the carbon dioxide to produce ATP, they build what we call lactic acid, lactate, 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 lactate. Okay, so it's like a byproduct. They build it like a byproduct. Let me see if I can get a pencil here. Good, I have a pencil here. Right. So this is the bloodstream. This is the cell. Okay. So something has happened. We are not getting blood, so this place is cut. But remember, the blood is bringing oxygen. Oxygen is stuck here. It's not coming. And when oxygen is being brought, carbon dioxide will be picked and sent. But because this place is blocked, the cells will say that, okay, let's now use the carbon dioxide to produce the ATP. ATP. But we will get a byproduct of what? Lactic acid. Lactic acid. Okay, that is what? This one is an acid. So it will increase the pH in this environment. And you realize that it will shift, the pH will shift below 7.35. Okay, yes. So what do we have to do? Quickly, we need to give IV fluids to dilute this. Okay, that's why anybody who goes to hospital with respiratory concerns, with level of consciousness alterations and all those stuffs, we do what? We check their lactate. We check their lactate. We check their lactate. Okay, to know what is going on. Who knows the normal level of lactic acid? If you know it, type it in the chat box. Sharp. So cellular dysfunction and organ failure. So continuous cutoff of oxygen and blood supply to an organ will result in what? Organ failure. Clinical example, we've had a car accident, a motor vehicle accident. Okay. You ask yourself, why is it that some people will get accident and they will die instantly? Some too will have accident. They will be working and even helping the responders, the rescuers, to save life. Within a short time, they will also collapse and die. And there are some people too, they will never die. Let the car crash, let all the metals of the car squeeze and crumple. Okay, they will never die. What happens is because of this guy, organ failure, organ failure, organ failure. Okay, so when blood supply and oxygen supply to an organ is cut, accident, something has cut the bloodstream and is bleeding, oxygen is not going to, let's say, the liver. Oxygen and blood is not going to the kidneys. If you get one organ failure, you can survive. Okay. There are some people, there will not be any cut to their bloodstream, or there will not be any crash, destruction of any organ after accident. So they are okay. But somebody will get, the impact was so high that the liver will destroy, the spleen will burst or rupture. Eh? The intestines will tear. If it is a woman, the uterus will also rupture. When it's the brain too is crushed. Okay, maybe the person was sitting in the front, not wearing seat belt. So the chest went to hit the dashboard, and now he's getting rupture, and the bone has pierced the lungs. So this one person is getting about 3 or 4 organs dying. This guy will die instantly if intervention is not quick. So it's about this organ failure. That's why a lot of people will be wondering, why is it that car accident, some will die, some doesn't die. I mean, some too. Yes. The guy who is walking and helping people and will die later. You know what happens? This guy was having internal, let's say this is the bloodstream, this is the organ. Okay. He has gotten what? A tear with the bloodstream. And the blood is dropping okay, outside. This organ is struggling for oxygen and blood. But because the blood loss is not that much and it is gradual, he will be strong to help people. Helping people means you got accident, you are helping people. Helping people means it's an activity, it's an exercise. Eh? And once you are not resting and you are exercising, your body organs will demand. There is high demand for what? Energy. Energy. And the blood is also being lost. So it what? Within a short time, these guys, the organs will also start dying. That is why somebody will be walking and helping people. Later, he too will collapse. And people will wonder, what happened? Yes. So that's the physiology, that's the electrophysiology. So if you are a first responder, if any accident happens in your community, let all the patients lie down and rest, whether you are strong or you are not. Once you are part of the accident, sit down. You can sit down, you can lie down. Don't put pressure on your body organs. Okay, because we don't know what is happening inside you. Okay. So we know the types of shock, we know the hypovolemic. I'm not going to go through all these ones because we've done it over and over and over. Every nurse on these platforms knows it. Okay. So the Nclex cues. This is where the scenario comes. They can give you, shock. Shock. So this is, let me take my pencil again. Good. So everybody knows in this world that these are the signs and symptoms of shock. So you get a question, they can pick 1, 2, 3, 4. This 4. And present it to you in the exam. Because you know everything and they give you only 4, they ask you what bow tie, what questions or what diagnosis are you anticipating? You are sitting down, you don't know what to do. Okay. So you watch out for hypotension. When you start seeing hypotension, tachycardia, altered mental status, decreased urine output, cold climate skin, weak peripheral pulses, elevated lactate. Sometimes if they want to trick and know that you know what you are doing, they can give you low BP, vital signs. Nicely, they will not mention hypotension. They will change English. Low blood pressure. Then maybe blood pressure 80 over hot 42, low BP. This is hypotension. And they will bring you lactate of 4.3. Okay. And they will tell you what the patient has or capillary refill, cap refill. They will say 3 or 3.8. Okay. And the skin, patient is having what? Cold, clammy skin and altered level of consciousness. This is a sign of shock. Okay. That is all you should know. So this slide, if you get it, if I were you, I'm going to die on it. I'm going to die on this slide. Okay. Right. So, what are your priority indicators? They are saying that with shock, protect your kidneys and what your major organs. And kidney is one of the priority indicator for you to know if it is an adult. If within an hour we are not getting more than 30 mils, okay, start suspecting what shock and start thinking about what your kidneys, your renal perfusion. Okay, your renal perfusion. Good. Let's look at another scenario, sepsis. Sepsis. Okay, so sepsis, we know that sepsis is what a major physiological adaptation topic. Because if we take 10 people to go and write NCLEX, 8 will get septic questions. So sepsis, what is sepsis? Infection. Infection will start from a small area. Eh? It will start from a small area, let's say on the skin. Along the line, these bacteria or whatever, they'll find their way in the bloodstream and start spiking your temperature, causing your body to be hot. Okay. Then once they are in your system, inside you have body fighters. They will try to fight whatever organism. Okay. But if they are overpowered, we call it dysregulated immune response. Okay. Inflammation is going to set in. That is why any sepsis, mostly itis. So imagine inflammation in the bloodstream. The capillaries will give way, they will become wide. So the plasma here will begin to what? Seep out. And because we don't have a lot of volume, there's going to be what? Vasodilation. This is the lumen. So you are dealing with two things with sepsis, especially severe sepsis, blood pressure, and what? Fluid loss. Okay. Should we allow this bacteria to stay here and be causing blood pressure to crash and fluid loss? No. So we will replace our fluid, we will give our vasopressors, then we will give what? Our antibiotics. But we don't know whether this bacteria is a male or a female. Example, we don't know whether this bacteria is it has wings or it doesn't have wings. So we want to know that type of bacteria. Is it gram positive or gram negative? Okay, are they rod? We learned it in microbiology. Are they rod or they are circle like this? So you hear the lab people will call you gram positive cocci in circles or gram positive rod. So you know the type of antibiotic to use for them. But because we don't know, should we wait? Because blood cultures can take sometimes over 24 hours to get results. Are we watching this bacteria to stay here? No. So let us give what? Broad spectrum antibiotics to attack them. Okay, so your vancos and your rosafens, okay, you give it to kill them quick. Okay. Now, because this bacteria cause blood pressure to drop and fluid to leak out, the cells here did not get the right amount of what supply. Okay, So what now happened? They will use the carbon dioxide here to generate energy to feed themselves. And I told you, we go back to the shock again. The lactic acid will start increasing up. So sepsis and lactate, I mean, you should do it. Okay, right. So what are the red flags? The questions will come. What are the red flags we are looking at? A patient will come to you with change in mental status and hypotension. Change in mental status and hypotension. They are red flags. Tachypnea, watch. Oliguria, elevated lactate, abnormal temperature, possible source. They are all possible source of infections. Okay. Do you know? If you don't know, don't worry. Once you have these signs and symptoms, once you have these signs and symptoms, start suspecting what? Sepsis. A patient with suspected sepsis who is becoming hypotensive and confused requires what? Rapid assessment and intervention. So we go back to the ABCDE again. Okay, rapid response. That's why last week we did rapid response so that you know how to take care of people. Okay, now let's go to the respiratory system. What are some of the scenarios we can look at? Okay, they are saying that in the respiratory system, our job, respiratory system, the job is even simple. Okay, it's either oxygen is coming down or carbon dioxide is going out. Okay, when oxygen was coming, what has stopped the oxygen from coming into the lungs? Is it an airway? Or when the oxygen got to the alveoli, are there some leakages here or issues, infections here that will prevent it from crossing? Are there some fluid here that will prevent it from crossing? Okay, so it's either oxygen or carbon dioxide. When oxygen is going down, we call it oxygenation. When carbon dioxide is coming out, we call it ventilation. So that mismatch is a problem. Okay, yes. So let's look at some of the issues. We have something we call hypoxia. So the question will come, hypoxia. You should ask yourself that we have two types of hypoxia according to the new curriculum now. They can give you a hypoxia that is in the early stage and a hypoxia that is in the late stage. So how will the nurse know that this patient who is having shortness of breath, blah, 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 this is having hypoxia, okay, but it's in the early stage? These are the signs and symptoms you see in the question. So they give you a respiratory question. The patient is having shortness of breath, like asthmatic patient, COPD patient. On top of this, they are breathing problems. They are restless. They are anxious. Their heart rate is high. They are breathing so fast and they have difficulty concentration. This should tell you that they are in the early stage of hypoxia. The cells and the brains are not getting. So they have thrown themselves into what? Hypoxia. Okay, let me try and clean some of the. Now, as time goes on and the cells don't get the oxygen and the brain doesn't get the oxygen, they begin to die. So the patients, that energy and the anxiety and the restlessness, it begins to go down. So they become more super confused. There is decreased level of consciousness. The heart rate that was tachycardic here will begin to go down, cyanosis and respiratory arrest. Okay, yes. Yes, the blood cultures will be taken before the antibiotic starts. Okay, yes. So That is it. So you can meet an airway question, shine your eyes. Is it restlessness? Is it early hypoxia state? Or there is a late hypoxia? Okay. So a change in mental status can be an early warning sign of inadequate oxygenation. Good. So clinical scenario, let's just take a patient with asthma. We know all the pathophysiology of asthma. We know our causes. Okay. They will give you a clinical scenario in the question: wheezing, dyspnea, coughing, chest tightness. You will meet any of these. Okay. And prolonged expiration. Asthma, that is their major problem. Wheezing on expiration. Okay. Yes. So they can list three of these and add a cardinal sign to it. Then they tell you anticipate the diagnosis, NGN, bow tie. Is this COPD? Is it emphysema or is asthma? The nurse must know. Physiological adaptation. Okay. Yes. So a patient with severe asthma who suddenly has very little or no wheezing may be getting worse. Don't think the patient is becoming okay. Okay. When you are managing a patient with asthma and suddenly they are quiet, auscultate their chest, please. Auscultate, don't check vital signs. Auscultate their chest. That should be your first attempt. You hear whether there is wheezing, whether there is air movement or not. That is where you know whether they are getting worse, they are deteriorating. So that silence is a big problem on the D, deterioration. Okay. Why? Because there may be minimal airflow. Silent chest is an emergency. God created a lot of gases in the chest. Okay. Nitrous oxide is there, carbon dioxide is there, oxygen is there. They are all moving, creating turbulence. So why is it that we listen to your chest and your chest there is no sound? Pneumothorax is also there. Okay, so with pneumothorax, all this sudden chest pain, dyspnea, decreased or absent breath sounds, tachycardia, and hypoxemia. Is it tension? So when it's tension, you always see what? The mediastinal shift. Okay, yes. So all these ones, you should know when you get a slide, you should know how to manage it under what? The new system. Okay, chest tube, a patient with chest tube. Chest tube was created oxygen, sorry, air, blood, and fluid from the pleural space. From the pleural space. So you should check when you see the question that is addressing chest tube, look at the respiratory status of the patient. They will surely mention it in the question. The breath sound or the breath sounds. Oxygen saturation, is it dropping? Drainage system in the chamber, is it working? The tubing connecting the patient to the drainage system, the connections. Okay, yes. So if you take this is the patient. This is a lot of people get confused with tubing and connection. Okay, this part is a connection. This one too is connecting to the patient. That's the connection. So here it can dislodge. There can be air leaks or air is gushing inside. Positive pressure. Or over here there can be leaks. And this is the tubing. Is it kinked? Something has punctured it. Is it leaking? Air is leaking inside or whatever. So that's what you should check. The water seal chamber. Okay. The water seal. This is the suction water seal. Okay. Yes. So you should check all these ones, the suction, all the chambers when you go to work. Eh? This drainage system, this is the drainage, this is the water seal, and this is the suction. Okay, that's it. So whatever fluid that is coming here will come and land here first before going to what the water seal, then suction out. Okay, so you should check all those ones when you go to work. Your colleague handed over to you, let's say the drain, the fluid was at 500 mils. You make a mark there. Then you write the time, 7 a.m. It was at 500. If your colleague forgot, if your colleague forgot, yes. Give me 2 seconds, I'm coming. Please, is my screen, are you seeing my screen now? Someone is saying the screen is not showing. Okay, so let me stop the share and reshare it. Good. Okay, is it better now? Are you seeing the screen now? Are you seeing the screen now? I have stopped the share and reshared it. Let me know. Please, those who said no, let me know from your angle if you are seeing my screen. Okay, good. Right. So you went to work, the drainage was at 500. You mark a permanent marker. When you close from work after your 12 hours, 7 p.m., you should mark where the drainage has gotten to. That one will help us to know, okay, whether this drainage system, whatever we are draining from the patient, is working or not. Okay, good, right. Yes, they are saying they can see it. They are saying they can see it. Okay, right. Okay, so when you are dealing with a drainage system question, the NCSBN is saying that consider these signs and symptoms. Okay, presentations. You will surely find some, they will blend and draft the question from it. So you should know how to do. Don't go and chew this babao. Okay, yes. Do not clamp or routinely clamp a chest tube. Okay, clamping can cause dangerous accumulation of air and cause tension pneumothorax in the lungs. Please, can you see? Somebody is saying they can't see. I don't know what is going on. Let me know if you can see my screen. Yes, okay, good. Right, let's continue. Heart failure. We know there's a different type. I'm not here to explain the types of heart failure to you. I want to show you what are the signs and symptoms you will see in the question. That would tune your mind. The clinical cues would tune your mind that this is heart failure question. Okay, so if it is left-sided heart failure, always think about the lungs. Okay, left-sided heart failure, the lungs, please. L is to L. This one, no baba. Okay, the left-sided heart failure, the left side of the heart is to what? The lungs. Okay, yes. So signs and symptoms of lung issues. Patient will be having what signs and symptoms of airway and pulmonary issues. That is it. T. This is so simple. Left-sided heart failure, the lungs. L is to L. So dyspnea, autopnea, crackles, pulmonary edema, all these one. You think somebody has pneumonia or someone has tuberculosis. Okay, is getting a left-sided heart failure. Right-sided heart failure, the jugular veins and the distended what? Distended jugular veins and the pedal edemas. Simple. You are done. Okay. So once you see where the question is coming from, especially crackles in the chest, crackles in the chest, okay, and frothy sputum. Okay, you have a sputum, a phlegm, sputum mixed with air. Okay, this is what a mixture of sputum and air is going to be frothy. Somebody is vomiting out blood or coughing out blood. When the blood came out, you are standing with the patient. When the blood came out, the blood is mixed with air, frothy. That should tell you that this is coming from the lung tissues. This is not an airway problem. I explained this to you last week, so you should know. So these are the things you should know that no, I'm having pulmonary circulation issues, left-sided heart failure. Okay, right-sided heart failure. Think about the body, systemic venous congestion. The venous system is failing, a build-up, backup flow. Okay, so the peripheral edema, the jugular veins, the patient will gain weight. There's going to be ascites, hepatomegaly, and all those ones. Okay, so you see pulmonary edema, and it can be linked. So these are the physiology. I don't have to go through all the physiologies. I'm explaining to you. You get a question. This is my focus, because if you don't get the clinical cue, the clinical assessment, if you don't get the direction of the question, you get the answer wrong. So pulmonary edema, be ready to answer what? Severe dyspnea, crackles. They can take three. A patient was rushed to the emergency department on assessment. Crackles were heard bilaterally. Patient was anxious, tachypnea, pink frothy sputum. That should tell you that, this problem, if it is not the left side of the heart, it is the lungs or the airway. So that is where my mind is. Okay. Seeing these signs and symptoms, as a nurse, you will not be thinking about what? Abdominal hurt or bowel obstruction. Okay. We are dealing the system where the complaints are coming from is either the airway or the left side of the heart. Okay. So you forget about all other what? Body systems. Now you ask yourself, patient is having crackles, dyspnea, anxiety. These three boys, which one can kill the patient first? That is where you start your treatment from. Prioritization, physiological adaptation, critical thinking. So the nurse who is sitting at the OPD, always tying people's hands, checking blood pressure, taking history. Before the patient will leave that desk to the doctor's office, the nurse should be able to triage that, these signs and symptoms. If we leave you to go and join the queue, you will collapse. So quickly go to the emergency room. That is it. Okay. So that we start emergency care. Good. So your priority action when you are dealing with pulmonary edema, you position upright, support oxygen, rapid assessment, which everybody does, then administer your therapies. Myocardial infarction, I have already explained it, but in the question, they can pick any of these ones for you. Okay. In the questions, they can pick a patient has come with chest pain or pressure. That pain is radiating to the arm, jaw, or back. And patient is having profuse sweating. Sometimes they can say patient is vomiting because the pain is too much. The pain is triggering the vomiting centers in the brain. So you saw vomiting, you saw pain, your attention is lost. Chest pain. You start thinking about pneumonia. Pneumonia patients, do they vomit? Okay. So they will add a classical sign. The pain is what? Is radiating to the arm, the jaw, whatever. Okay. Yes. Secondly, why is it that the pain is radiating to the arm and the jaw and all those ones? Okay. Because the heart is beating and the muscles of the heart will beat or contract to send the blood out. So the blood is coming out like this. Okay. So that radiation and the nerve issues to come in. Sometimes you will not see chest pressure, you will see pain. Okay. So when you see pain in MI, they will bring what? Pain is radiating. Sometimes you will not see pain, you see pressure. When you see pressure, the patient will talk, will have to describe the pressure. How are they describing the pressure? They will say that an elephant is sitting on my chest. Okay. An elephant is sitting on my chest. They can't breathe. Okay. So if you leave the line and you go, let somebody sit on your chest, you understand what myocardial infarction. Okay. So these are the major complications. A patient with stroke, whether hemorrhagic, whether whatever, okay, they will come with what? Their cues. So you should recognize this cue. Facial will drop, definitely. Arm weakness, speech will be difficult, sudden neurological deficit, time is brain. And always think about the last LKW time. So the question will tell you LKW. The LKW will help us to know the door to door, and the door to needle. Okay. If we have to take this patient to the cath lab to remove that clot or to repair that ruptured vessel, okay, we will know what to do. And the door, the patient to you, from the time the patient entered the door of the ER till you saw the patient, when should you give your meds? That's the door to door. Okay. So they will never give you what? A stroke question that you will not see any of these guys in. So this slide I'm giving to you, it is going to help you a lot if you learn it. A question on intracranial pressure. We look at the early signs and the late sign. The late sign will always come with the Cushing triad. And I told you that Cushing triad, you always think about what? Your blood pressure. If you look at the temperature, vital signs chart, we have the temperature, the pulse, or heart rate, temperature, heart rate, blood pressure, and respiration, TPR, BP, TPR, BP, TPR, BP. Okay, take away the temperature, deal with these three. Okay, in shock, if it is not intracranial pressure, in normal shock, the pulse will go high and the blood pressure will drop. But if you want to know the trick, in Cushing, if you know that this is increased intracranial pressure, there is going to, the blood pressure will rather go up and the pulse will either be irregular or it will drop. That's it. Respiration rate will go up, okay, or irregular respiration rate. That's it. That's the only difference. That no, this problem I'm seeing is coming from the brain. Increase intracranial pressure. Okay, increase intracranial pressure. Good. So They can add some of these. The patient is having headache, vomiting, especially those who can talk, those who are conscious. You do your people how you change exams, people change seizures, decrease level of consciousness. But these are the cardinal signs. So when you see this, then they will take one or two, add it to the questions and give it to you. So from the start, you know where the system, the problem is coming from. Okay, good. A declining level of consciousness is a major neurological warning sign. Good. DKA, let's look at how they frame diabetic ketoacidosis questions. So diabetic ketoacidosis, I said I'm not going through the physiology because everybody knows it. If you want to do physiology, we are not leaving the line today. Okay. So we are dealing with how they frame the question for you to know where the system is coming from. So DKA has all these signs and symptoms. They can take three signs and symptoms, frame it into a question and give it to you. They can take four. They can take five. So shine your eyes. Polyuria, polydipsia, dehydration, abdominal pain, nausea, weakness. But DKA will always come with a cardinal, Kushma. Okay. Sometimes they will not write Kushma. If they know they write Kushma, you know the answer. So they will write what? Rapid breathing. DKA people, their breathing is two forms. One, when they breathe, it's fast. At the same time, when they breathe, the smell of the breath is fruity. Fruity. Take note. DKA, when they breathe out and you are standing beside them, you will smell that nice smelling acetone breath. Okay. Fruity smell. And their respiration rate is high. So they can go 34, 35, some of them 40. That should tell you that the respiratory system is crashing. If the examiner, if NCLEX wants to be fair to you, they will add altered level of consciousness. That one you should do cross that or more. This question is cheap. If they delete this one and they change this English to make it rapid respiration or rapid breathing, that one is a typical strong question. So that is what you should also know. Okay. Let me try clean some here. So when I clear, otherwise when you get the slide, there's going to be a lot of writings on it. Okay. Let's go and look at some of the key concepts. The patient will always be severely what? Dehydrated. Okay, so in your management, think about your IV fluid, your insulin, and your electrolyte monitoring. Okay, HHS. This is a problem with what? Insulin. Insulin is not going. Blood is trying to sort itself, and the cells are sorting themselves. The ketones will build up because we are going to take fat and break it down to produce glucose. So the byproduct of breaking down is what? Ketones. Ketones building up in the system will cause issues. But over here, blood pressure, blood sugar is going up. Insulin is being produced. Okay. Here we don't have ketoacidosis. Okay. You don't have ketoacidosis. Their cardinals are hot. The blood sugar will go, sometimes they go 600, 560, about 500, 4 something, okay, late 400s, severe dehydration, and altered level of consciousness. So I've seen these three brothers. I did not see anything about respiration rate. I did not see anything about acetone breath. I did not see anything about what ketones. Don't jump to say this is DKA. They will mafia you. So shine your eyes. Okay, know your physiology. Good. So if an older patient, they can draft the question like this. An older patient who is having type 2 diabetes, nicely, they will come to you to the ER with extreme hyperglycemia, 500 and above, profound dehydration and altered level of consciousness. They've not mentioned anything about how the patient is breathing and the smell of the breathing and what and ketones. So don't go and say it is DKA. Take note. Good. Let's see how they will draft what electrolyte emergencies. Gradually, we are coming to an end. Electrolyte emergencies. Okay. So hyperkalemia is the first one. In hyperkalemia, if they want you to know that this patient is having a serious cardiac danger, that the heart is about to stop, eh, they will add this in. This patient is having muscle weakness, having paresthesias, they're having arrhythmias and EKG changes. When you see any of this, take note that what the cardiac is in danger. Okay. If they want you to know that this is a severe hyperkalemia question, eh, they will add these ones and life-threatening cardiac dysrhythmias and all those stuffs. Yes, that's what you should know. So, and hypokalemia, hypokalemia. Yes, there will still be what muscle weakness and what dysrhythmias because potassium pumps the P to P square. Potassium pumps your heart. These are some of the tricks you should know. And left ventricular failure will what affect your lungs. So L to L, P to P, potassium pumps the heart. So if potassium is needed to go inside what to help the heart to pump, and potassium level is high, the heart will pump faster and get tired and get arrhythmias and cardiac arrest. If the potassium is low, the heart will pump slow, weakness, still arrhythmias, heart will give up. So always potassium should be at the normal level. Okay, so they can bring you a questions like questions with mixtures like muscle weakness, fatigue, constipation. Everything is slowing down. That should tell you that no, let me go and check my potassium. Okay, potassium, you should anticipate what? The downness, low potassium, the downness. Okay, good. Sodium. Sodium helps with what? Nerve conduction and all those one. Nerve, nerve, nerve conduction and fluid maintenance. Nerve conduction and fluid maintenance. So why do people get seizures? Somebody is having hyponatremia. Okay, they will say that put the patient on what? Seizure precautions. Why? Because sodium is needed with nerve conduction. For a nerve to send information from one to another, sodium should be there and chlorine. Okay, so if sodium is low, the brain will struggle to conduct nerve. Okay, so you see the cardinal signs of brain issues: headache, confusion, seizures, and decreased LOC. In hypernatremia, think about the bones, the stones, the abdominal groans, and psychiatric overtones. Example: constipation, kidney stones, all this confusion. Yes. Okay. So these are the things you should know. When we have acid-base balance, they are saying go with the Rome. A lot of people know this acronym. Respiratory opposite, metabolic equal. I never like this acronym. ever since I was a student. I don't know why it never stick to my mind. Okay, I never like it. Okay, acidosis, acid base, so respiratory and what. So this is what I do. The trick I do, and which is very important. If you want to know this is what a metabolic problem or this is a respiratory problem, okay, cool. We have the respiratory system. This is the respiratory system. Okay. And this is what the cells. Let's look at it this way. Forget about the kidneys. Okay. Every other organ in the body and the cells. Let's call it a cell. Okay. So when I go to your respiratory system, your chest, from your airways to your lungs, to the bones, to the diaphragms, to the respiratory muscles, the sternocleidos, they all form part of what? The respiratory system. So if the question mentions that, sometimes they give you a scenario, patient had a stab wound, okay, on the chest and cannot breathe and building CO2. Okay, the person is describing the something has happened in the respiratory system. So if CO2 will build and pH will shift, this is a respiratory problem, a respiratory source. Okay, let me do the metabolic so that you understand it well. Somebody is vomiting. Okay, can somebody vomit from the respiratory system? No. So before somebody vomit, the vomit should come from what? The GIT, the upper GI, vomitus, and the lower GI is diarrhea. You can't vomit through your anus. Okay. So you ask yourself that is the gastrointestinal system part of the respiratory system? Yes or no? If the answer is no, automatically this is a metabolic problem. Somebody has got a crash injury, okay, crash the brain, not wearing helmet. And now the person cannot do anything. The respiratory system is the breathing and everything, building CO2. Okay. Because the problem is from the brain. Is the brain, the next question you should ask yourself is the brain part of the respiratory system? Yes or no? No. This is a metabolic problem. Somebody who is a known diabetic type 1, eh, when we are doing fasting in church, that person also wants to do some. Oh, pastor has given the person morale. Oh, you can do, you can do, you can do. When we fasted first day, nothing happened. Second day, nothing happened. Third day, this guy has started getting altered level of consciousness. Okay, and all those ones, weakness and stupor. Okay, yes. So you ask yourself, fasting, stomach, food, the things the person did before getting those issues, refuse to inject insulin. When we inject insulin, is it going to the lungs? No. When we eat food, is it going to the lungs? No. When we fast, is it going to the lungs? No. So definitely this is not a respiratory issue. This is a metabolic issue. That's the trick. Okay, that's a metabolic issue. Okay, good. Right. So that is it for the. If you know it this way, life is so simple for you. Okay, you go over. I think I need to organize a class for this one so that I teach you the others more tricks. But today we are not here for that. Okay. So if it is respiratory acidosis, you see all these signs, alkalosis, you see these ones. Okay. Metabolic, you see all the decay, the renal failure. So the diabetic guy, the renal failure, the kidneys are not part of the respiratory system. Okay, lactic acidosis, all this one. Patient is vomiting, gastric suctioning, diuretics. They are all not part of the respiratory system mechanisms. Okay, so definitely kidney injury. If somebody comes with kidney injury, how would they form the question? They say you should watch out for what? Reduced urine output. There is a rising creatinine. Creatinine. What is the normal level of creatinine? If you know the answer, put it in the chat box sharp. Your blood urea nitrogen is rising. Fluid overloading, circulatory overload. Okay. Hyperkalemia, and metabolic acidosis. So these are the things you should know. Okay. So whenever they want to set kidney failure questions, these are some of the signs and symptoms they will combine. Yes, 0.6 to 1.2. That's it. 6 times 2 is 12. Okay, good. So hyperkalemia can become an immediate cardiac threat because of the what? The potassium. Okay, good. Dialysis. A patient went to dialysis having complications. How would they frame the questions? They will definitely give you signs and symptoms because you need to know the situation. The S bar, you need to know the situation. If you don't tell me the situation, how do I manage the patient? Imagine a family brought their relative to you at the hospital. The nurse, we have come, treat the patient. What happened? We can't tell you. You are the nurse, treat the patient. We can't tell you. If you don't tell me your situation, how do I treat you? So the question will always ask for, give you situation, and that is what you should know. We will go through S bar very well. Somebody should write it down. Victor, if you are here, or Yarega, if you are here, S bar. Because it is one thing that is also killing a lot of nurses. S bar. When they see a question, they don't know which one is the current situation and which one is the background. Okay, yes. So the question in dialysis complication, if it is hemodialysis, you should expect what? Hypotension, disequilibrium syndrome. What is disequilibrium syndrome? If you know it, push the answer in the chat box. Sharp. Disequilibrium syndrome. We've done this over and over in class. Okay. Yes. Infection, bleeding, and muscle cramps. But in hemodialysis, we always want the fistula. You should know the breath and the trails. Okay. The stethoscope and what? Your palpations. The tongue, the T for T. The T for T in dialysis. The thumb for trails. So you use your fingers to do it. Never put anything on that arm. So you should put a restricted what armband to tell everybody that there is a fistula here. Okay, so nobody should put anything. No blood pressure cuff, no IV line, and no IV access on that arm. Okay, yes, good, good. So that one, disequilibrium syndrome, brain swelling after dialysis. So people will be getting confused. Some will even collapse and all those ones. And we rush them to the ICU. A lot of people they walk to the dialysis unit. While the procedure is going on, they will have issues, disequilibrium syndrome. Okay, yes, electrolyte issues. Good, burns. So a patient has come with burns. Your major priorities: the airway, the breathing, circulation, fluid resuscitation, pain, and infection prevention. Okay, so inhalation, if they want to test you, burns, all these things we are saying, tell me if you are not meeting it. So if you get a bench question, and they want to trick you. Let's say they don't want to calculate the burns percentage and whatever, but they want to talk about the inhalation clues. Because now, if the nurse is able to calculate the burn surface area but doesn't know how to treat the burns, what wisdom in it? Okay, you should be able to what? Identify that this is a burns case. How would the nurse know that this is a burns case? Situation, the current situation. So you can get what? Facial burns, singed hair, okay, then soothing around the mouth, hoarseness of voice. That's your your airway, upper airway, okay, coughing and respiratory distress, okay. So airway edema can worsen rapidly. So in burns, whatever you see outside, the same thing is happening inside. So if you see somebody's hair face is bent, don't think the inside is okay. Trouble has happened. Give them some time, they will start manifesting. Okay. So when you get the slide, when you want to treat burn questions, you know where to start from. Okay. Compartment syndrome. Those of you who go for the orthopedic issues, fracture, and all these repairs. When a patient comes back with compartment syndrome and the NCLEX wants to test you, they will give you situations like patient is having severe pain. They will describe it. Always they will describe their pain. This pain is out of proportion. I have never experienced this before. You give them pain medications, do everything. The pain is not going until you relieve that pressure. You do your neurovascular assessment, neuro and vascular. Okay. So the neuro and the vascular. Okay. So the neuro, the paresthesias will come, the vascular, this is a vascular problem. The pallor, this is a neuro problem. Weakness and paralysis is neuro. Pulselessness is a vascular. That's it. Those of you who wants to work in orthopedic units, always your neurovascular assessment. You should know this signs and symptom is neuro. This one is a vessel problem. This is a nerve problem. This is a vessel problem. That is what they say, neurovascular. Neurovascular. A patient has returned from the theater for orthopedic surgery. You do your neurovascular assessment, your 15 minutes for 1 hour, and your 30 minutes for 2 hours, then your 1 hour for 4 hours, and 4 hourly onwards. Okay, yes. So the neuro and the vascular always know what to. So this is what? Severe pain. This is what? A neuro problem. That's the trick about orthopedical. This is a pain, neuro problem. This is a pain, neuro problem. So if you don't do it this way, you never understand how to manage orthopedic cases. Okay? Yes. Good. So blood pressure crashing in a patient with orthopedics, that is not a nerve problem. That is a blood vessel problem. So it's a vascular problem. Okay. Always pulselessness is a late sign. The 6 P's. Do not wait for loss of pulse before recognizing compartment syndrome. You are going to amputate that limb. Good. The cells will die. Post-operative emergencies. Post-operative emergencies. Yes, we are meeting it too. Okay. So those of you who will be working in message, PACU, ICU, step down unit, yes, you prepare and hemorrhage. Somebody has come back from theater, is having a hemorrhage problem. How would they frame the questions? They will add these signs and symptoms to the questions. It can be three, it can be all of them. If it is all of them cross, you know where your problem is coming from. Okay. Yes, your urine output and pallor, increased drainage, and all those stuffs. If the patient is having collapse of the lungs, atelectasis, because they slept on the theater bed for a long time. Yes. So decreased oxygenation, diminished breath sounds, and low grade fever. These are the cardinal signs. You can't lie. You can't hide. Nclex can never hide. They have shown. You see, I said that I wish when I saw the curriculum 2026, I said, Omo, they have made Nclex cheap for you guys. Oh. Our time. Where are you going to find all this? This curriculum is telling you that this is how we want you to recognize the problem. They have already answered the question for you. If you don't have the curriculum, you are in trouble. You will learn everything in the world and you still not be able to pass. Follow the curriculum and you will pass. Okay. So a patient, the PACU-nurse, this is what you are supposed to do. Deep breathing exercise to open up the alveoli and coughing. If patient is unconscious and they cannot cough, you put them on a cough machine. If they can cough, yes, coughing exercises. Okay. Yes. A patient who has had abdominal surgeries, they put some pressure on the wound and they cough so that they don't cause a wound opening and all those stuff. Incentive spirometer also helps the airways to open up. And mobility, early mobility should be encouraged, especially patients, those maternity patients, when they finish giving birth, they don't want to get out from bed. Okay. Wound dehiscence and evisceration. Never, this is the classical thing. Never push an organ back. Okay. Never push an organ. Okay, sorry. Never push an organ back into what? The cell. Never put an organ. Okay. Never push an organ back into the cell. So this is what I mean. This is the abdominal wall. Okay, somebody went to do, let's say, appendicitis. Okay, yes, we have repaired. Now, pressure, intra-abdominal pressure went up. Intra-abdominal IAP went up, and it has pushed some of the tissues or organs out or intestines out. You are doing assessment. You went and saw fresh intestine hanging outside like this. Please don't wear surgical gloves to push it back. You don't know what is happening here. If you push it back and it ruptures, trouble has come. They can bleed and die. So what do you have to do? Find a gauze, a sterile gauze, wet the gauze, moisten it with sterile saline, and cover here with it nicely. Then you call the doctor. Hey, this is the easiest work to do in nursing. And notify the appropriate surgical team or emergency room according to facility protocol. Don't go and push somebody's. That is it. So, getting to a close end, getting to the close end, let's look at how will you know? Yes, I now know the situation of this patient. I now know all the clues, clinical clues. How will I know that this one will kill the patient first? What method will I use to know that this signs and symptom will be the one to kill the patient first? Because they'll ask you questions on that. Okay. So when answering physiological adaptation question, ask yourself, is the patient's airway threatened? You still use the ABCD formula. Is the airway threatened? Is breathing the B, breathing the B, oxygenation and ventilation, is it failing? Yes. So you got a patient, asthmatic patient who came to the hospital with shortness of breath. You connected nasal cannula and put it on what? 3 liters per minute. Oh, damn. Okay. 3 liters per minute. You put it on. After 10 minutes or less than, this patient is still complaining, shortness of breath, now cannot even talk. Okay. You change this one, the nasal cannula, to what? Simple face mask. You open it to maybe 10 or 8 liters. Still, patient is crashing, respiratory rate is shooting up, and patient is still complaining of shortness of breath. Now they are becoming weak and they are becoming confused. That should tell you that the brain is getting involved. The respiratory rate is so the brain getting involved is disability. A lot of people fail with this. The problem started with the airway. Okay, airway edema, airway is not relaxing, airway is closing. Now the brain is announcing its presence with what? Loss of consciousness, confusion. This is a disability. So when we look at the algorithm A, B, C, D, D is here. This is brain. Okay. So if I want to see which one should I enter first, or which one will kill the patient first? The A problem will kill the patient first before the D problem. So that confusion and all this in DKA patients, having all these guys, those ones are disability problems. Okay. Disability problems. It should not be your first focus. I'm teaching you this because if my family member comes to you, okay, you know what to do. Disability, somebody's muscles are tearing apart. They are crying of severe pain. Disability. Okay. Okay, let's go. Is there active bleeding? So you go to B, you go to circulation, bleeding. Is there active bleeding? Should I do something about it? If I don't do something about it, the patient is dying. Number 4. Okay. Is there altered neurological status? That is where you know you've gone to D. Is there severe electrolyte imbalance? D. Is the patient deteriorating? D. If yes, address the life-threatening problem before the less urgent problems. See, after these lectures, go and kill the Nclex for me, guys. So you know how to combine. You see, today we've learned how to combine the signs and symptoms. Then out of the signs and symptoms, you now fish them out like the post office master. This one will go under A. This one will go under B. This one will go under C. This one will go okay. Which one will kill the patient first? Sometimes somebody is having a mild this thing, SOB, shortness of breath. Okay, patient is not bothered, but it is still an A problem. Okay, yes, it is either A or B problem. And this guy who is having mild, he had an accident too. He is having what? Severe bleeding, multiple fractures. Okay, losing a lot of blood. Okay, that it has started affecting the vital signs, the hemodynamics. Okay, Yes, the algorithm says treat the A first before the B. But in trauma, if you do trauma nursing, in trauma will tell you that you will, in this situation, you will do the bleeding first before the A. Take note. This ABCD works for all situations, but in trauma, we sometimes rearrange it. So know how to go about it. If you do your trauma nursing when you come here, if you want to work in the ER, you do your trauma nursing. You learn these things. Okay. Yes, because physiology is not anatomy. That is robotic. Physiology, every day you have to learn. Clinical judgment. So after testing you on physiological adaptation, clinical judgment connection. Now you know your signs and symptoms. You know the one that will kill the patient first. Okay. You recognize your cues. Clinical judgment. You are coming to judge. So which of these ones is abnormal? Which of the labs is abnormal? Which of these signs and symptoms is abnormal? So patient denies shortness of breath. Patient denies pain. The denial alone tells you that it is not an abnormal situation. Then you analyze which of these signs and symptoms, which of these laboratory investigations, what do these findings mean together? What is going on? If you want to recognize cues, you prioritize, you look at the one that is most dangerous, then you generate your solutions to it. You take your actions, then you evaluate what your outcome. Okay. Don't memorize the disease. That is what they are saying now. The new curriculum says, don't go and sit down and memorize. Some people are learning only kill banks. They learn kill banks more than understanding the concept. But this morning I was telling one of you guys that NCLEX is a lifestyle. NCLEX, it does not end at the exam. It doesn't end there. It's a lifestyle. Some people will write their exam pass and exit the page. Okay, meet them 1 month. Give them the same questions they passed, they will fail. You are not a good learner. Okay. Make it a hobby, learning a hobby. You pass. Okay. So understand the physiological chain which we have done. Okay. So if it is DKA, is there insulin deficiency? Is there hyperglycemia? They connect. So the connection, where is it? The clinical connection will help you to know the diagnosis and treat the patient. The connection, the fat is breaking down. Definitely, there's going to be a byproduct of ketones. Ketones is building up. Ketone is an acid. There's going to be acidosis. How can this acid get out of the body? We need to breathe it out because it's a gas. Okay. If gas does not come out of the lungs, it will go through the anus. Okay. So if it is coming out of the lungs, how do we smell it? It is what? Acetone. The airway will start breathing fast. Okay. Shock. Good. Now let's do questions. So we are done with today's lectures. The rest is questions. We are doing 1 or 2 questions. I give the slide to you. So many questions on it. Go and learn. It is up to what? We have done 29 pages. It's up to 30, 60. The rest is questions, rationale, how to assess, how to do this. So this question like this, you try your hands on it. They will put a question. A client with DKA has blood glucose of what? 520. They gave you this question. It's very cheap. The question is so liberal and friendly with you. Because me, if you ask me to set these questions, I will not tell you the diagnosis from the start. No, the nurse must know. Okay. Blood glucose is this. The patient has dry mucous membrane. Blood pressure is 88 over 54. Okay. Heart rate is 124. Cushman respiration. Which finding requires the nurse's immediate attention or intervention? Okay. Which findings? So a patient is having PPH. Do you? I'll come back to your question. Okay. So let's look at this. He has given you what? The clinical situation or the current situation. Yes, this is the diagnosis. But the signs and symptoms, he has this blood glucose, one, dry mucous membranes, two, blood pressure, three, heart rate, four, Cushman respiration, five. So one, two, three, four, five. Which of these guys will you treat first? Okay. Which of these signs and symptoms will catch your attention first? They say appearance counts. So if you don't dress well, people will not admire you. So appearance is good. So the answer is what? Blood pressure. Okay. Blood pressure. Yes. Because the patient is showing hemodynamic instability consistent with severe volume depletion and impaired tissue perfusion. That is it. Good. They didn't choose Kushma. Why? Is this Kushma respiration a problem for the patient? If I breathe fast, I can breathe 5 hours the same way. I won't die. But let the blood pressure drops. Blood pressure is dropping, drop. Then today is like this. Tomorrow, 70 over 33. The next moment, 50 over 15. The next moment, 25 over 5. Patient cannot survive with this. You see? Okay. So somebody will say, oh, I saw this. I chose this. You're lying. Okay. Dry mucous membrane. Your mucous membrane is dry. Yes, it shows that you are dehydrated. If we don't bring in dehydrated and your only problem is dry mucous membrane, I've been talking for 2 hours now. Okay. I've been talking for 2 hours, 10 minutes. We have 50 minutes to leave this line. My tongue and my mouth, everything is dry. Does that mean I'm dying? So these are the things you should know. Okay, good. So these are the exam strategies that when you see sudden, I've added this one so that you understand. The questions will come with grammar. Okay. So you should understand the grammar because sometimes the answer is hidden in the grammar. So when we say sudden, think about what? Acute deterioration. Okay. Ayariga was sitting down talking with us. Suddenly, he started complaining, my head, my head, my head, my head, my head. Oh, this is an acute deterioration. Okay. Yes. The question, when you see this English, new onset, it is a new complication, a new situation that has been added to the already existing complication. So the new will catch our attention. The sudden will catch your attention as a nurse. Sometimes they bring the English worsening. That is a change in level of consciousness. Okay. Worsening. Good. Worsening. Think, evaluate. You need to evaluate the patient. Yes, those who have been working in care home. This patient went for supper. Oh, sat at the lounge, ate, slept. We all slept together. Okay. Now we woke up. When he was going to sleep, yes, he was not feeling well. We were checking the vital signs. Everything was going right. Okay. Though it wasn't that stable. But in the morning, the problem that is there already, eh, is it improving or going down? It's going down. Okay. It's going down. So this English and this English, they are never the same. They are never the same. So when you see this English, evaluate immediately as a nurse. The LPN cannot assess this situation. The nurse must do. Change in level of consciousness. This one everybody knows. Okay. So you see a question with what? So and so patient, change in level of consciousness, blah, blah, blah. You know that, oh, okay, the brain is either not getting oxygen or not getting glucose or not getting blood, or some of the nerves are tearing or destroying, a tumor, meningitis, infection, parenchyma issues. That's it. Don't, this one is not rocket science. You know. Okay. Absent breath sound. If you see this English in any question, think about what pneumothorax or airway problem. Okay, something has blocked the airway. Oxygen is not coming, carbon dioxide is not coming. Okay, there is no air mixture here. So you are not hearing any turbulence. So it is silent. That means that the airway is collapsing. Okay. Think frothy sputum. Air is mixing with fluid. Frothy. Okay. So pulmonary edema. When the vessels rupture, this is the lungs, and this is the pulmonary vessels. Sometimes the plasma here, it can leak out, especially when the patient has high blood pressure and the heart is pumping. The fluid can leak out, and the fluid will be here. And this blood pressure can destroy the capillary bed, and the capillaries will rupture. When they rupture, instead of fluid plasma, you now see what blood here. Sometimes, even in the alveoli can rupture, minor ones. Okay, so air will be mixed with blood, and patient will cough because it's a foreign body. You will cough anything. If you drop a pin in the lungs, the coughing reflex will be triggered. So you cough it out. When you cough, what came out? Fluid. The fluid was mixed with air. This one is not coming from the stomach. It is coming from what? This one. Okay. Sudden, hypotension plus tachycardia plus low urine output, we know shock. Sudden neurological deficit, think about stroke. So this English, okay, I'm giving you a big job. Then severe pain out of proportion. When you see this English in any question, start thinking about compartment syndrome, or there is a tear of muscle. It is a man, is it the scrotum? Yes. Testicular torsion. Okay. If it is a pregnant woman, severe pain, sudden severe pain. Okay. The placenta is torn, abruptio. Okay. Yes. So all this one, you should know. The spleen has a rupture, pain, sudden severe pain. Okay. So these are the questions I have for you guys. Let's do one or two or three, then I leave the rest to you. Then you continue. Okay. Good. So Let's start with sepsis and shock. Okay, good. A client, I'm coming. Is the font size okay? If it is too small for you, let me know. Number one, a client with suspected sepsis has a temperature of 39 degrees Celsius. Heart rate is 126. Respiration rate is 32. Blood pressure is 84 over 48. And new confusion. Which findings should the nurse consider the highest priority? So answers sharp. Send me your answers to the chat box. Yes. Answers to the chat box. I'm waiting on. Everybody should try. Good. Answers to the chat box. Yes. Answers to the chat box. Let me see your answers. Okay. People are choosing. Some are saying C, 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 C. Okay. So the answers are down. Okay. I don't want to go down, otherwise you know the next question. So let me read it from here. Yes, C. Those the C people are right. Good. So you prioritize your blood pressure over everything. Okay. Good. Let's look at this one. Question number two. A client with septic shock has received prescribed IV fluid. Good. Intervention is here. This is the diagnosis. Which findings will indicate that tissue perfusion is worsening? We have seen this English. Which finding will indicate that tissue perfusion is worsening? Is it urine output decreasing to 40 mL per hour? Capillary refill improving, level of consciousness decreasing, and heart rate decreasing from 120 to 98? Yes, answers. Sharp. Good. Yes. Everybody try your hands, so don't be a watcher. Okay. I beg you. Try your hands. When you get involved, you remember, we did it this way. And I also tried my hands on it. Okay. Good. Try your hands. I want to know if you are now knowing your clinical cues and also identifying what the major problem out of the lot, a patient with multiple problems. Yes, so the answer is C. Those of you who chose C, level of consciousness decreasing. This is a deterioration question. Deterioration question. Worsening. You see the English. Okay. A client develops shock after a major gastrointestinal hemorrhage. Which assessment findings should the nurse anticipate? Okay, this is an anticipation question. Assessment finding should the nurse anticipate? Definitely, it's the nurse that will do the assessment. But which finding, before she even does the assessment, which finding is she expecting to see? Yes, question number three. So always write your question number, then your answer. So example 3C, 3B, 3A, 3D. So what are you expecting? Is it bradycardia, hypertension, tachy, or bounding pulse? Yes. Question number three. Question number three. Yes. Good. Yes. It's tachycardia. Good. Question number four. A client with suspected hypovolemic shock has a blood pressure of 78 over 44. So we are suspecting hypovolemic shock. It is not confirmed yet. Suspicion. Okay. English. Blood pressure is 78 over 40. Heart rate is 138. Which prescription should the nurse question? Which, yes. So this is an intervention question, but out of what? Scope question. So the nurse cannot prescribe the medication, but she knows what should be given to the doctor did not prescribe it well. So the nurse wants to question the prescription. Which one will you question? Question number 4. Shoot. Question number 4. Question number 4. Yes. Question number 4. Which prescription? I like your answers. Question number 4. Which prescription would the nurse question? Which prescription would the nurse question? Question number 4. Which prescription would the nurse question? Yes, good. So the answer is yes. Yes. Okay. So the answer is D. Okay, fluid restriction. Looking at this blood pressure, okay, looking at the heart rate, this is a reflex tachycardia. We are suspecting shock. Okay, so definitely we need a rapid isotonic IV fluid. So if you chose A, that is not the answer. Understand the question though. This is what the prescription the nurse would question, not the nurse will anticipate. Take note. Okay. Number 5, a client with septic shock. Okay. A client with septic, please, number 4 is D, not A. Okay. It's D, not A. So take notes. You see where I know where you people are. Some those of you who chose A, I know why you chose A because of the English part of the question. Which prescription shall means there is nothing you can do about it. It is by force you must do it. You should question the doctor. Okay, or question the this thing. So four is not B. Continuous cardiac monitoring, hemodynamic instability. Cardiac monitoring is very important. So if you want to question, we will question the fluid. Why would the doctor tell the nurse that don't give this patient fluid? Okay, good. So open your eyes to the English. Question number 5. A client with, you know this English, is having it. It has been confirmed. With septic shock becomes increasingly, you see I'll show you the synonym of this. Increasingly confused and has urine output of 10 mils per hour. Which physiological problem should the nurse suspect? Yes. Number 5. Number 5. Number 5. Number 5. Septic shock becomes increasingly confused. Increasingly, ing, a continuous verb. Okay. ing, continuous verb. Confused. Okay. So the ing verbs in Nclex, it goes under what? Yes, increasingly. So this one, you see, the curriculum they gave us, they have changed the English to test whether we know what we are doing. Okay, yes. So this is a problem with tissue perfusion. Okay, decreased tissue perfusion. Those of you who chose B, you are right. So increasingly worsening. You remember when we were learning the grammars in the question, ing, 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 ing. So they will change English, but it's a continuous verb. Okay. So in ICU, people will be having worsening situations. You do your assessment. Okay. Question number 6. Hey, people are smart too. You are not even ready, but they are answering. A client with anaphylaxis develops swelling, wheezing, and hypotension. Which problem should the nurse address first? So we are talking about facial swelling, wheezing, and hypotension. Okay. So the question is saying that which of these four problems should the nurse address first? Is it skin itching, airway compromise, anxiety, and what abdominal discomfort? If you get this question wrong, I will throw you out of this platform. Okay. And this one, Nclex will give you 2 minutes to think about this question. Nclex will give somebody 2 minutes, which you can answer under 5 seconds. Yes, so obviously the answer is B. Okay, the answer is B. Now let's go to another session. Let's go to respiratory emergencies. Respiratory emergencies. Okay, they can frame questions like question 7. A client with pneumonia has an SpO2 of 84, respiration rate of 34, and increasing confusion. Which action should the nurse take first? Which action should the nurse take first? Which action? So then they have listed actions here. This is an intervention question. Intervention question. Remember, before you intervene, you gather your data, then you what? Prioritize hypothesis, then you intervene based on it. Intervention is divided into two. Is it within my scope or outside my scope? If it is within your scope, the nurse will do. If it is outside the scope, the nurse will anticipate. Simple. This is Nclex. If you go to Nclex with this plan, you pass all their questions and they will investigate you. Okay. Yes, so a lot of people have choose B. Okay, let me also copy them and choose B. Yes. So you assess and support oxygenation. Perfect. Guys are very good, oh, Charlie. I wish I was like you. You're, if NCSBN has made the curriculum like this, then it means they want you people to travel. Oh. They want you people to travel. Okay. Yes. A client with COPD becomes increasingly drowsy. So now you know your answer before you even finish reading your question. Okay. Which finding is most concerning? Number 8. A client with COPD becomes increasingly drowsy. Drowsiness is coming from which system? Which finding is most concerning? So, is it productive cough, barrel chest, shaped chest, decreased level of consciousness, mild exertional dyspnea? Yes, question number 8. Yes, question number 8. Please, question number 7 is B, not C. Okay. If I drew in T, chat me and tell me why you chose 7 as C. Yes, question number 8. Question number 8. Question number 8. Okay. Right. So question 8 is what? Decreased level of consciousness. C. Okay. So you see, you are getting the concept now. This grammar alone will bring your answer. Okay. A client with severe asthma initially has loud wheezing. Initially. See where they are changing grammar. Oh. So shine your eyes. Okay. 30 minutes later, the nurse hears almost no breath sound. The client is increasingly fatigued. A continuous verb question. What should the nurse do first? Or what should the nurse do? Okay, what should the nurse do? There is no first, please forgive me. Yeah, question number 9. Shoot your answers. You understand the question now. So shoot your answers. Let's go. Question number 9. Okay, okay. I got you, Kojo. I got you. Question number 9. Question number 9. Wow. Question number 9. 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 Yes. Right. So question number 9 is C. Immediately reassess respiratory status and initiate emergency support. Okay. Good. Question number 10. A client, bring it here. A client suddenly developed dyspnea and sharp unilateral chest pain. It did not tell us whether it is right or left. Breath sounds are absent on the affected side. Which complication should the nurse suspect? Yay! Yes, shoot. Question number 10. I love it. Hey, somebody is answering question 3. Oh. Where did you see question 3? Wow. Yes. Question number 10. Question. Oh, it's like people are having network problems. So. Naomi. Question number 6. Where did you see it? Your answer just dropped. Okay. Question number 10. Unilateral chest pain. Breath sounds are absent. What complication are we looking at? Yes, question number 10. Okay, so you saw it. When you see the signs and symptoms, you should think this way, think this way, think this way. Okay, a lot of people are choosing B, so let me copy them. It's B. Okay, good. Question 11. We have 25 minutes to leave, so let's be quick. A client with tension pneumothorax becomes hypotensive. Which physiological change best explains the hypotension? Is it A? Is it B? Is it C? Is it D? Becomes hypotensive. Question 11. Question 11. Yes, shoot, 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 shoot. People are thinking about the answers. Yay, pressure. Hey, tension pneumothorax. This is pure physiological adaptation question. This one, if you learn Q bank alone, you don't know. Okay. Yes. They are asking you which, this is a physiology that is ongoing. Among these physiologies, which one explains? Remember, the patient will come to you and tell you their problem. You ask yourself, what is causing that? Okay. The cause. Do I have any pathophysiology when we started? Is there any pathophysiology to link the two? This is the question for that. Okay. So, yes. Number 11. Okay, guys are coming home. Guys are coming home. Yes. Number 11 is decreased venous return to heart. Right. So this is the heart. Okay. And this is the lungs. Okay. And this is another lungs. We have veins bringing back blood back to the heart. Veins bringing blood back to the heart. Okay. There is a lot of pressure here. Sometimes the tension pneumothorax will even what cause the lungs to squeeze like this and put pressure on the heart vessels. Okay. The vessel leaving the heart, sending blood away, we will experience what? Capillary refill, perfusion issues. But the vessels bringing blood to the heart, when pneumothorax press on it, it will squeeze it. When it squeeze it, you will not get a lot of blood to come to the heart. So there's going to be decreased venous return. This one will crash your BP. Okay. So what do? You are living in a village. We don't have any interventional radiologist or we don't have any experienced medical doctor. Somebody, but people ride motor, people drive cars, get accident, crash injury. They have come. You listen to the chest, it's silent on one side. Okay. You did your X-ray, you saw that there is a pneumothorax. What do you have to do? You have to relieve pressure. Okay. The pressure that is generating in the lung, in the chest cavity, is crashing the lungs and also crashing your vena caves. So venous return is going to be in trouble. Okay. And you will see this with your blood pressure. Blood pressure will drop. Okay. So a client receiving mechanical ventilation, let me squeeze it a bit, suddenly has an increase in peak airway pressure and decrease oxygen saturation. Okay, this is a ventilation question. Which action should the nurse take first? Question number 12. Where are the ICU boys? Yes, come and answer for me. Yes. Mechanical ventilation. The peak. What is peak airway pressure? And what is the normal peak airway pressure? Decrease oxygen saturation. Which action should the nurse take first? Okay. Which action? Oh, sorry. Is it better now? Yee. Okay. Which action should the nurse see first? Okay. Yes. Those of you who work in care home, work in the neuro unit, okay, complex care, patients, you see a lot of patients on what? Ventilator. Okay. Yes. You are welcome, Genevieve. Okay. So everybody is choosing B, and the answer is truly B. You airway clearance. Pressure in the airway. This is not a lung problem, it's an airway problem. So pressure, anything it can swell, it can be mucus, you can suction it, okay, and all those ones. 13, a client with acute respiratory distress has an SpO2 of 78% despite oxygen therapy. Wow. Which finding indicates deterioration? This is D question. D question. Deterioration. Okay. I guess this one I even explain it. All. Yes. Number 13. Number 13. You remember the hypoxia issue. The hypoxia issue. The hypoxia issue. Yes. So a client with acute respiratory distress, okay, has an SpO2 of 78. You are giving oxygen, but still the SpO2 is dropping, which finding indicates deterioration. Yes. So increasing restlessness. Okay. This is an acute problem. Acute hypoxia. Acute hypoxia. Okay. Or early hypoxia. Early hypoxia. Okay. Oh, Patricia, you chose B. Patricia said mild test. Okay. Okay. Plateau. Okay. No matter what you pass, don't worry. Okay. It's better to get it wrong now. Okay. Question number 14. A client with pulmonary edema is severely dyspneic and coughing up pink, frothy sputum. Which position is most appropriate? Ha. We saw this topical. Number 14. Pulmonary edema. Severely dyspneic. Wow. And coughing up pink, frothy. He even has the strength to cough. Jesus. Okay. Yes. Darling. Yes. Yes, this one everybody knows the answer. So high Fowler's position, okay. High Fowler's. Let's go to cardiovascular issues. You choose one question, then we move to the next. I'll give you the slide. You go and chill it. We have 16 minutes to close. A client report crashing substernal or below the sternum chest pain. Let me explain that in English for you. Not above, or below. Okay. So, or under the sternum. So, a client report crashing substernal chest pain radiating to the jaw and left arm. Okay. The client is pale and diaphoretic. Wow. Which action should the nurse prioritize first? This is an intervention problem. These people are smart too. They give you the signs and symptoms, then they tell you to intervene, not even to diagnose. Yes. Question number 15. Shoot. Yes. Question number 15. Shoot. People are smart too, Charlie. Okay. Question number 15. Good. Yes, I like the way you guys are answering the questions. I like it. You're trying your best. Yes. Question number 15. I'm watching everybody's answers. Good. On my little monitor here. Question number 15. Yes. So everybody is choosing A. Obtain a focused cardiovascular assessment and initiate the acute chest pain protocol or the MI protocol. Okay. Good. 16. A client with acute heart failure develops severe dyspnea, crackles throughout both lungs. Wow. And an SpO2 of 80. Which complication should the nurse suspect? This is what? The last, after evaluation, you are looking at complication. Ah, these people are smart too. See how they have thrown you. Okay. They gave you the signs and symptoms, and they are saying use the signs and symptoms to answer complication question. Wow. See the distance. They jump physiology. They jump diagnosis. Okay. They jump intervention. Now they are here. Link signs and symptoms to complication. Charlie. Okay. Wow. So if you do it like this, yeah, I'm not teaching you only to pass English. I'm teaching you to be a good critical thinker. Okay. To be a good critical thinker. Okay. So question number 16. The answer is what? Yes, let me go and see your answers. Wow. Okay. So hey, people are choosing C. O. Wow. Somebody said dehydration. Yee. Some people are choosing D. Somebody said pneumothorax. Maybe you know something we don't know. Okay, it's good. It's good to make the mistakes now. Eh? It's good. Don't worry. A client with acute heart failure develops severe dyspnea. Ah, heart failure, left to lungs. Okay, so yes, we are seeing the lung problems. Dyspnea is part, crackle is part, SpO2 dropping is fat. Okay, so this is a true heart failure question. Which complication should the nurse suspect? So you now take off the dyspnea, the crackles, and the SpO2. Okay, pulmonary edema. Pulmonary edema, no pneumothorax. Okay, crackles in both lungs. This is the lung. When you blow a balloon, after this class, go and buy a balloon and pour water in the balloon, blow it and leave it blown and pour water in it like this and shake it, cring, 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 like the way we have the maracas. Shake it, that sound crackles, crack, 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 crack. That is it. Tension pneumothorax will lapse the lung. You see this big alveoli. Tension pneumothorax will make it small like this. You will not hear any sound. Silent chest. Okay. So you will not hear anything. So I mean the answer is what A. Pulmonary edema. The crackers alone should tell you. Okay. Okay. 17. Which finding in a client with heart failure requires the most immediate intervention? Okay. So let's see how they have done the connection. So, which finding in a client with heart failure requires? So we say heart failure. We'll go with lung or either the left. Sorry, left is lung, and right is the body. Okay, good. So which findings will require most immediate intervention? Okay. So what they are saying is all these signs and symptoms. Which one will kill the patient first? If they give you the authority to rate, which one will kill the patient first? Yes. Ah, my hand. Oh, my hand. Ankle edema, weight gain, 1 pound in a week. Will it kill the patient? Let's give these people 1 week to live. Which one of them will die first? Yes, answers. Click, 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 click. If you are confused, ask yourself, let's give this patient 24 hours. Which one of them will die first? 1 week, 2 weeks? Which one will die first? That's my answer. Okay, 17. A lot of people are choosing this. So, pink frothy sputum and severe dyspnea. This one cannot last even more than 3 days if you don't do anything about it. 18. A client with cardiogenic shock, a pump problem. Cardio, heart. Genesis, the beginning or the source. So, heart, pump, shock. Has a blood pressure of 76/42. The skin is cold. The pulses are weak. The mentation is altered. Which finding best indicates inadequate tissue perfusion? So they have given you this, this, and that. Which findings? Your data. This is a data collection of data. Okay, assessment indicates inadequate tissue perfusion. Inadequate. My blood pressure is low. My skin is cold. My brain is altered. And my pulses are weak. Inadequate. Yes, so everybody, me, I'm copying you. Yes, so everybody will go for altered mental status. Cool. 19. A client develops, we have 6 minutes to say bye bye. Okay, I'm not going past 3 hours. I told you every day that we do 3 hours, we leave. A client develops sudden chest pain, dyspnea, hypotension following an acute myocardial infarction. Sudden, that is the verb. Which complication should the nurse suspect? Jesus Christ. These people are wicked though. They give you signs and sentences and they link to complication. Charlie, wow. It's too far. Yes. They will not even tell you that, which condition are we anticipating? Complication. Yes, 19, shoot. A patient develops sudden chest pain, like I'm talking with you then. I can't do anything. Sudden. Eee. Dyspnea, hypotension, following an acute MI infarction. Number 19. We are answering 19. People are answering 20 already. Hey, please give me answers for 19. Okay, number 19. Yes. Cardiogenic shock. Cardiogenesis. Okay. 20. A client with heart failure has gained 3 kg in 3 days. So WW. Which additional finding will be most concerning? 20. Yes, answers 20. If you know this acronym, WW, you are done. Physiology is nice. WW, L for L, or R for B, right back. The T, P, R, B, P. Cancel the T, reduce the P, increase the R, increase the B. What condition? The same T, P, R, B, P. Cancel the T, increase the R, reduce the B, and yes. Cring, 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 cring. Okay, so the WW. Heart failure, kidney failure, all these failure, liver failures, fluid retention. Water is equal to what? Weight. So your body is filling with water every corner. Okay. Your body is filling with water. If you know this trick, you know it. Water, WW. Okay. Your water is weight. Somebody has nephrotic syndrome. Eh? Somebody has liver failure. Okay, WW. So every day your body is filling with water. So which of them will be a concern? Crackles. If you hear crackles in the chest, hey, water has filled now in the chest. Oh more. This patient will die. Okay, guys, we have 2 minutes. Try your hands on 21. Then I say bye-bye to you. I give the rest to you. Go and answer it. But come back tomorrow for our quiz. Our 90 questions quiz. Our 90 questions quiz. Okay. A client suddenly develops facial dropping. Jesus, you know the answer. Right arm weakness and difficulty speaking. What information should the nurse obtain first? Hey, this one is data collection, assessment, 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 assessment. Yes. I have a homework for you. Who will do it? IVIG protocol. IV immunoglobulin protocol. Everybody should go and read about it. We will use 5 minutes to finish that tomorrow before we start the class. Yes. Question number 21. Question number 21. Question number 21. I trust you guys. LKW. Yay! LKW. Last known well time. It will help you with your door to door and door to needle. Okay. So please, IVIG protocol. Everybody should go and read about it, please. Me, I've told you I'm an ICU and ER nurse. So that is the level I'll take you to. Message. The questions there are cheap. So before patient go to message, they have already stabilized them. so, so okay, let's do a teaser. A teaser. I have my temperature. I have my pulse. I have my I have my heart rate. I have my blood pressure. Okay, and I have my respiration. Okay. A teaser. I have cancelled my temperature. I have increased my heart rate. I have decreased my blood pressure. Okay. And I have irregularities here. Irregularities. Yes. What complication are you suspecting? Sharp. Shoot your answers. Let's go. I want to know if you remember what I told you. Yes. You're in there. Hey. Okay. Wow. Good. Okay. So that is shock. Okay. Let's do the same thing. The same temperature, heart rate, some will say pulse, blood pressure, and respiration rate. Okay. I have cancelled my temperature. I don't want it. I have reduced my heart rate. I have increased my blood pressure. And still, my respiration rate is having irregularities. Sometimes it is even high. What complication am I looking at? Teaser. Yes. Answer this one, and I say bye bye to you guys. Heart rate has dropped. Blood pressure is up. Respiration rate sometimes up, sometimes irregularities. Yay. Somebody says hypertension. Yay. Clap for the first. Mrs. Everest. Wow. Hey, somebody says heart failure. Clap for the person. See, I've cancelled my temperature. Oh. I have reduced my heart rate. I have increased my blood pressure. I have irregularities with my respiration rate. Yes. Mrs. Everest is laughing at me. Mrs. Everest, come again. As for this, your hypertension, I won't take. Yes. Okay. Please, if you haven't liked the page, like it. If you haven't subscribed, subscribe. Okay. I want you to be part of the journey. Make sure you subscribe. Subscribe to the page. Subscribe to the page before we leave. Subscribe. Hit the subscription box. You don't pay. Everything we do is free. Let the more you subscribe, the more YouTube will connect it to a lot of people so that they join, so that they will benefit. That is it. Okay. Subscribe, 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 subscribe. Yes. Okay. So some are saying ICP, some are saying Cushing triad. I'll give it to all of you. Okay. If the question gives you ICP, take ICP. If they give you Cushing triad, they will never miss them. Take Cushing triad. Okay, these are the signs and symptoms. The Cushing triad. But it is the cardinal sign of Cushing triad. If you meet the two, if they want to stubborn, if they meet the two, take Cushing triad. Okay. Which I know it will never happen. But when it happens, pick the Cushing triad. Okay. Yes. Guys, thank you so much. I need to go back to bed and prepare for night. So I'll finish my night shift tomorrow morning and I have 8 days off. So we can crack, we can make more fun online. Yes, so please, we are not using our Zoom again. All classes on YouTube. I'm tired of recording and people will be complaining. Say you did not send the recording. Say you did not send my iCloud is finished. It's full of recordings. Okay. So let's use YouTube. YouTube, we don't pay. The videos will be there 1,000 years. Go and watch it. Okay. Go and watch it. Okay. That is it. So please. And bring people. Let them join. Bring people. You know, Zoom was charging us every month. Okay, yes, one of our people were paying it. Okay, so please, I've told the person that it's okay. Don't worry at all. Let us use YouTube. YouTube, we don't pay. All these things we are doing, we don't pay. It's free. So it's all about you subscribing, liking, and sharing so that people will know. Okay, YouTube is an algorithm. The algorithm, the AI will start sharing it to people. Okay, yes. Then people will join. When they join, then we will also propagate the word to the whole world. Okay, so please, let us help. It's not only me doing it. All that means Nicholas is busy. That's why you are not seeing him. He's super busy with school. He's schooling. Okay, everybody wants. As a man, you need cash now. So, so we need to improve school so that we can get money and take care of our wives. So that's why the ATT group, we are not seeing him lately, but he will join very soon. Okay, before the month goes to an end, he will join. Please, I'll send the slide. Make sure you learn. See, plenty questions on all that. We've not done endocrine, so do it. Mark yourself. Renal failure and electrolyte disturbance. We've not done it. Okay. Acid base imbalance. Train yourself. Burns and trauma. Okay. Post operative complication. Train yourself. Okay. Then, yeah, that's it. And these are the rationales. These are the rationales. I have a message for you. I know a lot of people are watching us. Read this. This document is not for sale. It's for philanthropic purposes. That is why we opened the page. All the admins, we came together to say we want to do this for free. So don't take our slides and go and post it on your paid channel. At the end of the month, people will be paying you money for our work. Not do not use it for any financial gains. It belongs to our platform. Okay. Yes, you can give it to people to learn, but don't go and charge them for money. Okay, let's be honest to ourselves. Okay, so in short, now the curriculum is 9 areas. Whether you like it or not, if you have not written your NCLEX, they are going to test you in 9 areas. So the 9 areas, we have safety, we have psychology, psychosocial psychology, we have basic care and comfort, we have pharmacology and parental therapies, we have clinical judgment. Okay, we have health promotion and maintenance, we have physiological integrity, we have reduction of risk potential, we have physiological adaptation. Okay, so and we have management of nursing care. So we have a long way to go, but at least with how we are learning, I believe, is it this new curriculum is so simple and so cheap. If you are smart, you can use 1 month to finish in class because 9 areas. Physiological adaptation, we have done it today, so it's out of our way. We have done a management of nursing care. That one too is out. So tomorrow we will do our quiz, and Thursday, let me see, Thursday we prepare for pharmacological and parental therapies. Pharmacological and parental therapies. When you get the slide, don't sleep over it. Okay, read, learn, go deep, analyze. and be a better person. Thank you so much, and God bless you all. Okay, God bless you all. Thank you so much. I leave you. Let me share some love to you. You can also share some love to me and some smiles. And let me give you eye opening. Bye bye for now. Okay. If you want our number, I'm dropping my number on the page. Okay. 975-495-3875. Chat me, but not today, tomorrow. I'm going to work tonight. Okay, I have 2 hours to leave. So there's my number, my WhatsApp line. Okay, I've dropped it. Please chat me on WhatsApp. And if you have any concern, we talk about it. Okay. If you have any help, this is a free page. If you have any help to help, if you have any, now we want somebody who will edit our videos. So if you are very good with video editing, you chat me backstage. Okay. Yes. See this page as your own. You are part of the group. You are part of this organization. We own it together. Okay. Yeah. Thank you so much. God bless you all. Bye bye for now. We've done 3 hours. Good. Bye.